I am John Korfmacher. I'm a senior research fellow at Chapin Hall at the University of Chicago, and I'm a member of the HARC leadership team. I am very pleased to be a moderator of this panel that's focused on improving outcomes for meaningful subgroups. Spoiler alert, those two meaningful subgroups are fathers and caregivers with high level of adversity and parenting stress. I encourage you, as you listen, to think about common themes and questions that emerge from these two very different presentations. At HARC, as you all know by now, a big focus is on thinking about how home visiting can differentially impact outcomes. So how can programs best approach work with these two groups of caregivers? Our first presentation is by Grace Hubble. She's an associate professor of psychology at the College of Charleston and a practicing clinical psychologist. Dr. Hubble's work focuses on promotion of child well-being through community programs, including home visiting, Head Start, and early care and education. She will be followed by Neil Guterman, who is the Paulette Goddard Professor and Dean Emeritus at the NYU Silver School of Social Work. He's been conducting research in the field of early home visitation for well over 2 decades, and he wrote one of the very early scholarly books way back in the halcyon days of 2001, entitled Stopping Child Maltreatment Before It Starts, Emerging Horizons in Early Home Visiting Services. Before NYU, Dr. Guterman served on the faculties of Columbia University School of Social Work and the University of Chicago Crown School of Social Work Policy and Practice, where he also served as dean. In both cases, after the presentation, we'll have time for 1 or 2 immediate or urgent questions, but we plan to have time at the end for further discussion and questions. We will wrap up at the bottom half of the hour, and then there will be a short 10-minute break until our second breakout sessions begin. So with all that, let's get going, and let's begin with Dr. Hubble.
Hi, everyone. I'm going to go ahead and share my screen. All right. So thank you all so much for having me here. It's an honor to be a part of this group. Today, I'm going to talk about a study that focused on improving communication about reproductive health for mothers with high levels of adversity and parenting stress. This was a collaboration between myself and Bette Williams, who is the Chief Communications Officer at our Children's Trust here in South Carolina, and was a true champion for this partnership. The study was funded by a Research to Action grant from the Doris Duke Charitable Foundation. These are an opportunity for members of a network that I'm a part of called the Child Wellbeing Research Network, and they're awarded to a team of researchers and a policy or practice partner with the intent of designing and implementing an applied research project in close collaboration with that partner that focuses on a child wellbeing policy or practice question. And it was wonderful to work with the Children's Trust of South Carolina. So in partnership from the beginning with the Children's Trust, we developed a project. The short-term goal of the project was improving communication about reproductive health care for mothers enrolled in programs like home visiting. The Children's Trust funds multiple programs that aim to prevent child abuse, and the majority of them are home visiting programs. In the long term, our hope was that if mothers who are enrolled in a program like home visiting are more aware of and more likely to use reproductive health, they'll have greater reproductive health autonomy, and there'll be improvements in their well-being and their family's well-being. Some of the research that supports the rationale for this project included evidence that problems related to poor health and stress during pregnancy are risk factors for family adversity, as well as evidence that interconception period fertility planning can lead to reductions in child maltreatment. What we did was a survey project where at the end we showed mothers a series of ads that told them about available reproductive health services in their community. At the beginning of the survey, we asked some questions to figure out which of these different groups that I talked about at the beginning they might fall into. I don't think I need to go over what adverse childhood experiences are for this group. What I'll say about our measurement of ACEs is that we included the traditional ACEs that you all know about. And we also assessed an expanded concept of ACEs that are more likely to occur in the community. So things like racism and living in an unsafe neighborhood. We also used an established measure of parenting stress. And then we looked at a construct that I'm going to go into more detail about called regulatory focus. And I'll talk more about that on later slides. Regulatory focus is a construct from social psychology. And broadly, it gets at the type of goals that individuals are most likely to pursue. And it appears to be something that is useful to use in the framing of health messages. So there are two types of regulatory focus groups that individuals tend to fall into. The first is people who are driven by a prevention type of regulatory focus. These are individuals who are more motivated to avoid losses and failures. So when I talk about this to my students, I'll tell them that these would be the students who study really hard for an exam because they're thinking about what would happen if they failed the course. In a broader example, this might be the person who, when you're thinking about your finances, somebody who's more likely to save money because they're thinking about that emergency situation where it would be a bad thing if they didn't have funds to pay for it. The other type of regulatory focus group that people tend to fall into is promotion. So this is people who are more driven to achieve success. So this is going to be the student who's studying really hard because they might have a goal in mind of their GPA or they're thinking about getting into graduate school. And the person who's saving money because they're thinking about a number that they want to have in their savings account or something that they want to purchase for themselves with those savings. So neither category is something that we want to avoid people falling into. These aren't negative outcomes in any way. They're just individual differences. So we asked mothers questions in this survey, and then at the end, we showed them a series of 6 ads in 3 groups that were about reproductive health services in their community, and they varied in the ways that are outlined on this slide. So we had a prevention framed ad and a promotion framed ad. We had an ad that described services that were telehealth and an ad that described services that were in person. And we had ads for services that were just for the mom herself, and then ads for services that were about reproductive health care, but also addressed partner relations. And I'll show you the ads that we developed in just a minute. So this is just another way of taking a look at kind of our project in a using the precision paradigm. And so what we were looking at here in terms of the intervention was a light touch. It was messaging about reproductive health that varied in the ways I've just discussed. And we were wanting to find out how these messages might have differing influences on our proposed mechanism of action. So motivation to seek reproductive health services. And we are also interested in the context. We wanted to see how that light touch intervention of messaging might work differently in different contexts, specifically for mothers exposed to a high number of ACEs and those experiencing higher levels of parenting stress. And again, our intended long-term outcome was better reproductive health for mothers. So these are our ads. This first slide shows our prevention and our promotion ad. I'll kind of go over these in detail because these are the ads that are probably the most difficult to see the differences in at first glance. So our prevention ad is the first one reading left to right. And it says avoid unplanned pregnancies, pregnancy complications, and sexually transmitted infections. So those negative future outcomes that people might be motivated to have not happen to them. Protect your health. And then it says all women ought to receive high quality and confidential reproductive health services, and that you can relax knowing your rate will be based on a sliding scale, helping you avoid high costs. So again, that negative outcome that they might be thinking about when they're considering reproductive health care. The other ad is our promotion ad, which says, plan the size of your family. I need to move my slides over just a minute. Have healthy pregnancies and stay sexually healthy. Take charge of your health. And this says accessing high quality and confidential reproductive health services is a goal that you can meet for yourself and your family. Rates are based on a sliding scale, so you can gain affordable care. So these are our prevention and our promotion framed ads. This next set of ads are in person and our telehealth ad. So one is just depicting services that would be delivered at a local clinic, and the other one is depicting virtual care services. And then the final set of ads depict services. One would be just for the mother, and the other would be for the mother, but also addressing her relationship with her intimate partner. Okay, so what we were able to ask among the participants who completed our survey was first how ACEs relate to regulatory focus. So I'm not sure if I said this before, but we also had an established measure of one's regulatory focus style in the survey. And we knew from some previous literature that had been conducted by other groups and a study that I'd conducted at the college that individuals with a high level of ACEs tend to be more driven by prevention regulatory focus. And so we wanted to kind of look at that and ask that question with mothers involved in programs like home visiting. Then we also wanted to find out which ads participants would find most persuasive and to take a look at what worked for mothers with high levels of adversity and high levels of parenting stress. And then we also wanted to see if a congruency, a match between a person's self-reported regulatory focus style and the message focus might make the ad more convincing. This has been researched quite a bit with many different groups of people, and it seems to usually play out that when you show somebody an ad that's matched with their regulatory focus style, they're more convinced by that ad. And with our data, we are also able to take a look at whether or not that was especially true for people who had been exposed to a higher number of ACEs. So we were able to collect data from 481 mothers in South Carolina. We distributed this through communication channels through the Children's Trust of South Carolina. So there were flyers that were delivered to participants in home visiting programs. We put it out on the Children's Trust social media sites. And we can't say what programs the people who completed the survey were participating in, but we know that they were all mothers living in South Carolina. In terms of their relationship status, it was a predominantly married group of women. They were on average 33 years old, and it was a majority white group with about 30% of our participants being Black. This slide shows what we found out in terms of the ACEs that the mothers who participate in our survey had been exposed to. These numbers are pretty on par with what you would expect given nationally representative data on ACEs. So moms had experienced about 3 ACEs on average, and many people had experienced none, and much smaller groups had experienced very high numbers of ACEs. Where things get a little bit different and maybe show that this was a group exposed to higher levels of adversity that might have been more impactful for them was when you look at the breakdown of the ACEs they were exposed to. So we had a pretty high number of women who were exposed to sexual abuse and physical abuse and witnessing domestic violence. We had a much lower number than you would expect given national data of people who reported the divorce or separation of their caregivers. They were mostly married themselves, so maybe we had a lot of moms who were raised in 2-parent households, or maybe we had a lot of moms who were raised by single mothers. We don't know, but those numbers were lower. And then in terms of expanded ACEs, this is a pretty new area of research, and we had pretty high numbers across the board. So many people reported a lack of neighborhood cohesion. We had pretty high numbers of food insecurity, and many people also reported experiencing racial discrimination growing up. So the first question we were able to take a look at once we got our data was how ACEs related to regulatory focus and parenting stress. And here we found things that were consistent with previous research in this area that had mostly been done with college students. So we found that a higher number of ACEs was associated with a higher level of prevention regulatory focus. And then another expected finding was that a higher number of ACEs for mothers were associated with a higher level of parenting stress. What we did next was looked at the persuasiveness of ads across the entire group. And here we found that the prevention ad was more persuasive for the entire group. And the ad that addressed partner relations was also more persuasive for the entire group. We didn't find any differences for the whole group in terms of the in-person and virtual care services. And then we took a look at the role of exposure to adversity and ad preference. So we compared people who had experienced a low number of ACEs to people who had experienced a high number of ACEs. And we found that for people who had experienced a low number of ACEs, the prevention ad was more persuasive. And no other significant differences in between the high ACEs group and the low ACEs group. The only other thing that I'll point out on this slide that I do think was important was that people who experienced a high number of ACEs were just more likely to say that they'd use any service that we showed to them, regardless of how it was advertised. And then we took a look at a group of mothers with low scores on the PSI, the Parenting Stress Index, and compared them to a high PSI group. And some more significant differences emerged here. So what we found here was that people with a high amount of parenting stress, they were more persuaded by our prevention framed ad. And then when we looked at the in-person and the virtual services, we found that parents with a low level of parenting stress were more likely to say that they would use virtual services. And then parents with a high amount of parenting stress were more likely to say that they would want to use the service where partner relations were addressed. We also took a look at the role of regulatory focus in messaging. Just remember that overall participants were more persuaded by the prevention ad. And next, what we found was that people who reported a high level of prevention regulatory focus on the measure of that also found the prevention ad more persuasive. But people with high promotion and low promotion also preferred the prevention ad. In the low ACE group, those with high prevention regulatory focus found the prevention ad more persuasive. But those in the high ACE group had an equal preference for the prevention and the promotion ad. So some things that were expected and some things that were a little bit different than what we expected in terms of regulatory focus. Okay, so next I'm going to walk you through my messages for administrators of home visiting programs and home visiting programs that are home visitors themselves. So kind of the good stuff, what we learned from doing this work. So these are my recommendations for home visitors and for policymakers related to home visiting. First, I would say increase the availability of reproductive health services and communicate about them to mothers who've experienced a high number of ACEs. So if you're working with a group of mothers and you know they've experienced a lot of adversity in their life, it seems to be the case that really, regardless of how you're communicating to them about reproductive health, what they were saying to us is that they wanted those services. And so at the administrative level, if you have a partnership with an OB's office or a place that provides reproductive health services, I think, work on that partnership and then just tell moms about what's available in their community, especially if you know you're working with a population that has experienced a lot of ACEs. My next take-home message is that if you're thinking about how to frame these services or other types of services, the prevention ads may be persuasive to many. I think in this field, a lot of times we tend to focus on the positive when getting families involved in a lot of different types of services. But it just seems that these prevention framed messages worked a little bit better, especially for those exposed to less ACEs and those currently experiencing parenting stress. My next take-home message is that telehealth services may be the best fit for parents experiencing low levels of parenting stress. This was a surprise to me, maybe not what I expected when I wrote the grant. But after working with women on Zoom who are experiencing parenting stress in the moment, I definitely get this finding and understand that, especially when it comes to reproductive health, for those who are experiencing a high level of parenting stress, that privacy and confidentiality and the true knowledge that you're having time with your provider just for yourself may be what's preferred. And then finally, maternal reproductive health services that address partner relations, they seem especially appealing to all the mothers who we surveyed, especially those experiencing parenting stress. So these are what I'd recommend in terms of talking to moms in your program about reproductive health care. Finally, I want to talk about next steps, the next kind of project that I'm embarking on with the Children's Trust. And that I would certainly love to involve other home visiting programs in. So doing this project was really informative. Again, it was a light touch, but it was really interesting to just find out more about how we can best communicate. And so what we're going to do next is a very similar study, but we are going to look at in our ads, ads that communicate that it's okay to ask for help with parenting and enroll in programs like home visiting. So we're going to vary some ads, use regulatory focus message framing, and maybe some other ad differences. And that's like our next study. And I'll stop there. I can answer any like urgent questions at this point.
Grace, I think what we're going to do in the effort of just because of time,
okay,
why don't we let people, if they have questions, they can put them in the, if they don't want to wait, they can put them in the chat to you. And then, but I want to make sure we have time at the end for some more general questions and answers. So I think we should transition over to Neil. But thank you, it was great. And I know you were presenting a lot of information in a limited window of time. And so thank you for being conscious of that. And now I think you can stop sharing because we're going to have Neil is now going to share his screen and Dr. Guterman is going to do his presentation.
You see that okay? And
yes,
hear me okay? Okay,
yeah,
beautiful.
perfect.
Thank you so much. Let me just sorry, adjust my screen here a little bit. Okay, thank you. Okay, so whoops, let me get to the first slide. Okay, first of all, thank you so much for including me and for introducing me, John. As John said, I'm on the faculty of the NYU Silver School of Social Work. My colleagues, Jennifer Bellamy et al., have been working on and are really pleased to release some newer findings from our Dad's Matter randomized controlled trial. And from the outset, one of the things I would like to say is that our work aligns really well with the precision home visiting framework, which focuses on what works for whom, and in particular, I want to underscore in what contexts. In the Dad's Matter study, whereas home visiting has traditionally focused on the mother-baby relationship, our work widens that lens and focuses on one key aspect of the social context of early childhood mothering by looking at the role of fathers and considering how we can optimally deliver home visiting services so that they're fully father inclusive. So first of all, I'll provide some rationale for this work and why we think fathers are a critical missing piece in the home visiting field. Then I'll detail our work on building an evidence-based father inclusion enhancement to strengthen evidence-based home visiting models. And specifically, I'll touch upon our developmental pilot work and then present to you some of our early first findings from a recently completed randomized controlled trial examining a father inclusion enhancement to home visiting that we've dubbed Dad's Matter, presenting some brand new findings, especially focused on physical child abuse risk per se. So time only permits a very quick and sort of cursory overview, particularly of some of the methodological details. So I'm going to sort of skim over that. And so if you want further information, certainly feel free to reach out directly to me. You can see my email at the bottom of the screen. As we all know, we continue to witness good growth in the early home visiting services in the United States and other countries, in large part fueled by an overall set of outcome studies that have been very promising. And given the recent growing recognition, of course, of the sensitive period of early childhood for later life development. Despite promising outcome findings, it's also important to acknowledge that the evidence base is also mixed, where some outcome studies on home visiting have shown, for example, no benefits associated with home visiting. Some have shown positive benefits that then wash out soon after a follow-up period. And almost all home visiting studies, most of them have shown only modest impact in terms of magnitude of benefits. I argued in the book that John Korfmacher referenced in the introduction that part of the reason for this is I believe that model programs we rely on have been designed with a mother-baby focus, and most don't sufficiently grapple with the social contexts in which early child rearing is taking place. So given this, my team and I have focused on one critical gap in home visiting, namely on the key role that fathers play in young children's development. So for example, a rapidly emerging evidence base is pointing out that fathers play a key role in risk for child maltreatment in young children's cognitive, psychosocial, and mental health development. Also, recent findings have pointed out that fathering quality can significantly shape the mother-infant attachment qualities, and positive father involvement can serve as a buffer to children's risk for both physical abuse and neglect. Having said that, of course, fathers are consistently found to be disproportionately involved in the perpetration of physical child maltreatment, particularly in its most severe forms, which are concentrated in early childhood. And then finally, specific to home visiting services per se, some recent evidence indicates that fathers can also significantly shape the effectiveness of such services themselves for mothers and babies. So despite this growing evidence base, we're aware of less than a handful of studies to date that included fathers as study participants or as intended primary service recipients in home visiting, most of which have shown little or no impact on child or family outcomes. As just one example, a recently published randomized controlled trial of the Safe Care model, which then was adapted to focus on fathers, reported no effects on child maltreatment outcomes. The most promising model that we've seen to date uses a more elaborate and more expensive male plus female home visitor pair, which adapted the Family Foundation's model to home visiting, recently reported by Bob Ammerman and his colleagues, and reported some positive outcomes, for example, on parent-infant attachment quality. So notwithstanding this one promising study, which employs a second male service deliverer, which raises questions about real-world scalability, we present here we have presently a very thin evidence base from which to understand how best to home visiting programs can address fathers' roles in promoting positive child and family outcomes. So we believe that, putting simply, that fathers are a clear and critical missing piece of the puzzle in advancing effective home visiting services. So with this in mind, then, we conducted an exhaustive review of the scientific literature examining father influences on child and family outcomes, on existing evidence-informed strategies that could be useful for home visiting. And we then carried out a series of focus groups where we listened carefully to the needs of fathers, mothers' views of fathers, and fathers' roles, and home visiting staff vis-a-vis fathers and home visiting services per se. And then based on this information, we blueprinted and then pilot tested a father inclusion enhancement to home visiting services with the aim of seeing if we could feasibly and with good uptake engage fathers in the context of standard home visiting services, and to see if the father inclusion enhancement could show promise of improved outcomes, at least in a preliminary way. So in our small pilot study, which again we dubbed the intervention Dads Matter home visiting, which I'll detail in just a moment, we were able to demonstrate that feasible implementation of this enhancement within the context of home visiting programs with good fidelity to the model. And we showed intended changes in home visitors' work with families. So just as one example, whereas 1/3 of the families that received simply regular non-enhanced services received any type of father-focused or co-parenting intervention activity, 100% of the families in the Dads Matter enhancement pilot did. And we further found that Dads Matter families had higher father and mother retention in services. So for example, in the Dads Matter enhanced group, 100% of mothers and 92% of fathers were retained through the course of the study to its end, in contrast with 75% of mothers and 44% of fathers who received just standard home visiting services. This was, of course, a small pilot, and where we also examined outcome trends, which of course are not experimental, but here we found a very promising and broad array of positive trends that mapped onto our theory of change, including favorable changes in the mother-father relationship, quality, lower parenting stress reported by each mothers and fathers, greater self-reported father and audio recorded father involvement with their babies, and importantly, lower physical child abuse risk by both mothers and fathers. And we reported this in 2018 in Child Abuse Neglect Journal, so you can reference that. Or, but before that, let me just give you a quick overview of what the Dads Matter enhancement looks like. So here, I don't know if you can see my cursor, but here, these are standard services as usual, but then what we add on via the home visitor, not via any other worker, an assessment process and an engagement process focused on families, focused on fathers, excuse me. The intervention itself now is manualized with a joint live training, which complements and naturally extends home visitors' normal practices, and it doesn't replace or supplant existing evidence-based practices or add new staff. It can be delivered at all levels of home visitors, whether they're have higher advanced degrees or are trained on the job, and can accommodate varying home visiting evidence-based models. We intentionally designed it so that it could flexibly be adapted to a variety of family structures, co-parental relationship qualities, fathering roles, and ethnicities. And it's grounded in a family systems theory and is family rather than merely mother-baby centered. And it's fully father inclusive from the start of services throughout the end of services. Dads Matter has 4 overarching practice aims and is tailored to address the specific needs of families drawing from the modules listed on the slide here. The 4 primary components are assessing fathers' roles in the family and the ways that this can be improved, managed, or enhanced, engaging fathers in services when appropriate and safe and in a supportive and productive co-parenting role with a mother, building and working to improve or strengthen the co-parenting team between mothers and fathers, providing direct support to fathers regarding manages the stresses and challenges that are unique to being a father. So the Dads Matter enhancement is concentrated in the first 4 months of service from initial intake until families are well settled in to home visiting services. And one of the things I just also want to say is we designed this originally, given that it was a pilot and early on to focus on biological fathers. So for now, we are not able to say anything specific with regard to other father figures who are not biological dads, like let's say granddads, stepfathers, or paramours. So after the pilot study was successfully completed, we were able to carry out a multi-site randomized controlled trial, which is a gold standard to assess the impact of the new Dads Matter intervention, whereby families were randomly assigned at the program level to receive either regular services or regular services plus Dads Matter. And then we compared outcomes from using data collected at a baseline at the point of service initiation, 4 months after Dads Matter was fully delivered, and then 1 year follow-up. We were able to successfully enroll 204 families, and you see the eligibility criteria at this point. The only thing I would like to is point out eligibility criteria is that the biological fathers needed to be potentially engageable. For example, if they were geographically not nearby or incarcerated, we did not consider that family eligible. So in the findings I'll report in just a moment, we were focusing on physical child abuse risk as an outcome, but we also, previous to these findings, recently published in the October issue of Prevention Science Journal that dads matter under our randomized controlled trial conditions increases the worker's delivery of intervention specific to fathers, increases fathers' participation in home visiting overall, and improves the father-worker relationship. So having established that, then we're looking at whether those improvements lead to improved outcomes for families. So here I'm going to focus on findings specific to physical abuse, which is our first incursion into looking at outcomes from this study. And also we are looking at a few key mediators and moderators of impact, which I'll show you in just a moment. Okay, so just very quickly, we were able to enroll 204 families across both study conditions, both mothers and fathers. We were able to achieve retention rates of 91% of mothers and 85% of fathers at the 4-month follow-up period. And then at the 1-year follow-up period, we retained 85% of mothers and 80% of fathers following the beginning of services. And in our final sample, you can see that about 2/3 of our participants were Latinx, about 1/4 were Black, about 3/4 were married or living together, with the remaining majority still romantically involved. Mothers' mean age was about 25 and fathers about 28. About half of the sample were first-time parents. About 3/4 of the services initiated were begun after the baby was born. And in those cases, the baby averaged about 14 months of age. And this was largely low-income sample in the greater Chicago metropolitan area, with 85% of mothers on public assistance, and about 85% of fathers were working part-time. Okay, so let me walk you through this slide, because this really summarizes in a pretty dense way some of the findings. And we used here a statistical strategy called structural equation modeling, which some of you may be familiar with. It's a strategy which can trace not only program effects from intervention randomization to the outcome, but also the mediator variables that explain the outcome that might be observed. And that is from graphically shown in this particular slide from left to right. So in this analysis, we controlled for sample clustering at the level of teams and within agencies, and we arrayed variables in a temporal order to make a strong causal case that we're observing here. So let me walk you through this in a little technical way, and I'll just go through a few steps of what this pathway, this diagram shows. First of all, if you can see my cursor, if you start from the far left, which is the randomization Dads Matter enhanced services versus standard home visiting services, we can see following through these pathways that all of the pathways are statistically significant from the intervention condition all the way through to the outcome of mothers and fathers' physical child abuse risk. And so we can establish, also looking at the overall indices, we can establish that the intervention indeed can be shown to drive down mother and father physical child abuse risk at 1 year later. However, if you look at this particular path coefficient here, what we did is we split the sample into those where the parents began services after the baby was born, postnatally, and before the baby was born, prenatally. And here we see the intervention not showing effects when the families were enrolled prenatally prior to the birth of the child, but we do see the program benefits for those families where the baby was already born. For those families specifically, we see then what happens is that the Dads Matter intervention strengthens the worker relationship with the father, and that explains then improvements in father's support toward the mother at 4 months of age. Looking at this path coefficient, which then explains both mothers and fathers' lower use of partner abuse with the other partner, mothers toward fathers, fathers toward mothers. And this then explains at 12 months, this is measured at 4 months, this explains later lowered physical abuse from both mothers and fathers. And additionally, we see that the improved relationship with the father itself independently predicts improved mother's risk or lower mother risk of physical child abuse at 12 months. This is sort of a pathway that we still need to figure out what are the mediator variables in this pathway that we haven't figured out in this model here. But essentially, we see that overall, for postnatal families only, we see a program effect. Okay, a couple of other things that I want to point out that I think are important is for those of you that follow the effect size in the home visiting field and know standardized path coefficients, which these are modest to mild effect sizes. That means they're not dramatic findings. But if you also are aware of some of the meta-analytic work in home visiting, you see that these effect sizes are on par with the overall positive benefits that we've seen in the home visiting field writ large. So just summarizing then, we've learned across the pilot study and now the randomized controlled trial that Dads Matter as a light touch enhancement with low cost training and a manual can be implemented feasibly, safely, and organically with workers. And at least for families enrolled in services postnatally, the Dads Matter improves fathers' engagement in services and their relationships with their home visitors. And this leads to improvements in fathers' supportiveness towards mothers and lower physical coercion and abuse in the co-parenting dyad, which then leads to lower physical abuse risk by both mothers and fathers at a subsequent point in time. So, of course, like any study, it's important to point out some limitations. For example, we don't yet understand why Dads Matter doesn't appear to benefit families enrolled prenatally, though we're thinking this through right now. Obviously, all of the families that were enrolled were only in the Chicago metropolitan region, so we don't know how generalizable this is. And it only applies to, as I said earlier, where their biological father is potentially engageable in services. We can't say whether this extends to non-biological father figures. And finally, we're still examining some other outcomes in our data set, like children's developmental milestone attainment and other risks. But given these positive findings, we're now beginning to focus work on larger scale dissemination activities of Dads Matter in other settings, as well as making adaptations to other contexts. So I think that summarizes. I want to make sure I acknowledge our funders, our partners in the community, the parents that engaged in the study, and all of the entire Dads Matter research team. You can reach me directly if you like at that email address, or you can scan the QR code on the right hand, which will take you to my website directly, which will connect you directly with some of these publications here. There's a couple that are still in press or under review. So again, I welcome your follow-up queries and interest in partnership and with Dads Matter and extending that potentially. So thank you.
Thank you, Neil. That was great. Again, very impressed with how much information you were able to present in a short period of time. And thank you for walking us through the model that you had on the previous slide. I think that was really helpful. We have about 5 minutes at this point. So I want to open it up for questions that people might have for either Dr. Hubble or Dr. Guterman right now about their presentations. Grace, I know there were a few questions in the chat after your presentation. I don't know if you saw those, but one of the questions was, did number of children in the family matter in the analysis you did? And another one is about why the focus on married women? Was that just a matter of who the sample was, or was it because of where you're recruiting from? And then Mark Innocenti has some very specific questions about the bar charts, and I don't know, that might be something that, given how little time we have, that might be better followed up that might be more something you follow up on.
Sure. I can answer actually like all those questions pretty quickly, and then certainly to follow up about the last one.
Okay.
So in terms of the first question about differences related to number of children, we haven't looked at that yet, so I don't know the answer. And then the focus on married women was completely unintentional. We were just able to focus on the people who took the survey, and it just happened to be a large number of married women. It was kind of like still COVID-y, pandemic-y time. We paid them all $25 to take the survey, and I think we just got a group of women who were motivated by the payment for completing the survey, but also had the time to take it. It took about an hour. And so maybe the married women had a little bit more support with childcare. And then on the bar charts, I may be able to help you with that one, and I'm certainly willing to follow up, but to help, you're comparing the bars of the same color to each other, not the bars with two different colors to each other. And I think if you look back at them, you'll see that those lines aren't really overlapping, but I'm happy to answer more questions about that. And I may not have made the perfect bar chart either. So I'm happy to answer that one in more detail later.
Grace, do you think the fact that you had so many married participants in your study, do you think that might affect why you saw that one finding where they resonated more for the message that involved the partner versus ones that didn't involve the partner? Do you think that might be a function of the sample that you have?
Oh, definitely. Yeah. So I think that another, we could probably look at this like through data analysis. But I think another like answer to that question is that like mothers who are partnered are going to be more motivated by services that address that relationship than mothers who are going through this on their own. And that if you want to show two different ads, one to a single mother and one to a mother who's partnered, it would certainly be a good recommendation to show the partnered mom, the one about partner relations.
Yeah, absolutely. We still have a few minutes left. Any other questions?
Is it okay if I just ask the question? And I
think absolutely. You can put it in the chat.
I am so new to this home visiting space, but I am focused, or my research is focused on maternal health and paternal health during pregnancy and afterwards. And I was at a maternal health and substance use disorders, that's the population, mothers with substance use disorders. And I'm saying that because I just came from the NIH, and we were looking at maternal health and substance use disorder outcomes and things that are being done. I was challenged with services there was a lady, a mother, talking about her experience and not having access because she lost her child. So she went through the same things. She went through her postpartum depression. She went through all of the things that a person, a birthing mother would go through, and needed support, her and her husband, but she did not have support because she didn't bring her baby home. So my question really is around eligibility, and then how is maternal health and paternal health addressed outside of that connection with the parenting role, or is it in the home visiting program? And maybe I'm thinking now, maybe that isn't a question for this group, maybe it should have been the policy group, but anyway, would a person like Candace be eligible for this service because she, her baby died. She did not bring the baby home, although she went through the same maternal processes as a person and her husband. She actually said we ended up getting divorced, and in large part because they didn't have the support they needed to navigate that process of losing a child. So I just wondered if you could speak to that about eligibility and maternal health, sort of mental health support, paternal support in the mental health space for parents who don't, bring home their child for whatever reason.
And Neil, you have about 1 minute to answer that question.
Okay, I guess I'll take a crack. But I actually think there are probably others on the screen that can answer this maybe better than me. So I'll do this with all humility that I'm in the room with lots of others very well-informed folks. But my understanding is that home visiting programs require a baby to be, because the focus is on parenting per se. They're not designed for, let's say, bereavement, parental bereavement and loss of a child. So I think that the eligibility question is really critical. I think the other thing I would quickly say is that, at least on the father's side, father's mental health, even when there is a child and the family is eligible for services, is much overlooked. Substance use is a problem, is much overlooked, both fathers and mothers, but especially, as my presentation and our work tries to point out, the importance of overlooking fathers' mental health and substance use challenges is really critical.